Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Jenny Shields. She's a licensed clinical psychologist. Today's Kevin MD article is DSM-5 doesn't name it, but moral distress is everywhere in medicine. Jenny, welcome to the show.
Thanks so much for having me.
All right, so tell us a little bit about your story and then the reasons why you shared this particular article to Kevin MD.
Yeah, well, thank you. It's May, so it's Mental Health Awareness Month, right? I'm a clinical psychologist. I have a background in bioethics and health policy. And I think with it being the month of May, we're hearing all kinds of buzz around mental health awareness, and what people frequently comment
Mhm.
on your show about burnout in medicine and sort of where we're at as a whole right now. So I do a lot of work with folks that are facing just that.
All right, so for those who didn't get a chance to read this particular article, what's it about?
Yeah. So I'm kind of burned out on burnout talk, right?
Hmm.
Like we are doing so much of it, and in and of itself, it's almost become a buzzword. And while we've moved the conversation forward around burnout, I think in a lot of ways, we're still behind in the field of psychology, really thinking about what type of treatments help this type of problem, and really, is it a problem? This nuance of, are we pathologizing something that is just a natural response to stress? And so what I talk about in the article is just that when we are forced to work in systems that continuously and persistently put us in a space that is not designed to support our well-being, and in fact actually damages that on a regular basis by putting us in these compromising positions, that we are seeing the natural progression of that. And yeah, so just that we as a whole are working to combat as a problem that really exists right now in the field.
So you mentioned that you do a lot of work in this area. So for some of the people who come to see you from the healthcare field, what are they describing? Why are they coming to see you?
Yeah, yeah. They usually show up with a very similar presentation. They're exhausted. And I think that's the part we would label burnout and can identify pretty clearly. But one step beyond that is this moral distress, which is this: I'm going to work. I got into this to try to make things better for the people that I serve. And I'm finding that I can't do that in in the ways that are being prescribed for me. My caseload is this size, or my documentation is whatever we're facing, and insurance companies and all of that. And so they're really asking bigger questions around, is this something that's sustainable? Can I
Mhm.
continue to do this? And certainly, how do I then navigate my decision making based upon the debt that I'm carrying, based upon the fact that my entire professional identity has become wrapped up in my career as a physician, as a nurse, of whatever it is. Unpacking that together is a lot of the work that I do.
Why is it so important to make that distinction between burnout and moral distress?
I think it starts with whose impetus is it? Who's the impetus on to change what's happening here, right? Resilience is almost become a dirty word in my vocabulary, right? The idea that a provider needs to become more resilient, that it's something they need to fix within themselves in order to be able to continue to perform in a certain way. When we talk about moral distress, though, what we're looking at is a broken system, a system that needs to adapt and change. And the consequence of responding to that broken system as a single individual is this moral residue, is this harm that comes to the provider, because medicine as a system is not something that any one individual can change. And so the fallout from that, then, in labeling it as moral distress, is a values-based discussion about what is the work we want to do, and we're perhaps being prevented from being able to do successfully.
So you introduced that term moral residue. So explain why that's not alleviated by typical self-care strategies that's often recommended for burnout and sometimes requires system change.
Yeah. Well, I mean, just thinking about how we approach this, psychologists, therapists, often you'll come into the therapy room, and many of your listeners have probably heard of something like cognitive behavioral therapy. The idea that we have thoughts that are negatively impacting our mental health and well-being. And suppose you were to come see me in the therapy room and you tell me something very real, not anything that's distorted, but is just the fact of the matter that because of the length of stay initiative at your hospital, you're being pressured to discharge patients before
Mhm.
you believe that it's time to do so. It would be so improper, but certainly not beneficial to you for me to say, well, if that's what you need to do, how is that distorted thinking about needing to move them out of the hospital more quickly? Let's work to reframe that thought. There's only so much you can do, this and that. And it invalidates the very real experience
Mhm.
of this sort of moral consequence of I'm being asked or pressured into doing something that I very much believe is not the right thing to do.
One other term that you introduce is institutional gaslighting. So tell us exactly what that is, because when you wrote about it, I found that concept pretty compelling.
Yeah. I think anyone who's spent any time in a large healthcare system or been to an administrative meeting has probably at one time or another experienced this, where you have people standing up on high who are making decisions, who have a perspective or a narrative they've been given around what needs to occur. And
Mhm.
maybe that's coming from a place that is well intentioned, but fails to really see what's happening on the ground. There's this experience of when you're just struggling to keep up, and maybe you hear somebody in administration say, well, we just don't have the money to do that. We just can't make the decision to implement this or that, or we're going
Mhm.
to have cuts again. And you were already at a place where you thought this is not sustainable. And you hear one more thing, but you see actions that are counter to that. I remember once hearing somebody having to count the sheets of copy paper that they were using to print things on to, to meet expectations around budgeting. And yet they look at the break room in the executive suite and they
Mhm.
go, why am I counting copy paper right now? And then from there, it's the requirement to put your head down and act aligned with that narrative, to sort of pretend as if, yep, I'm on board with this and I'm aligned, when you know very well that that's not the case. And sort of the emotional exhaustion that comes from showing up and pretending each day really starts to wear on people after a period of time.
So we've talked about, of course, moral distress and the powerlessness that a lot of clinicians feel when experiencing moral distress. So, talk to us about some initial steps that you counsel them on when they come and see you, for instance. What are some things that needs to happen in order to address this issue?
Yeah. I've thought a lot about what is it that we, my colleagues, what do we need in order to get support? Because quite frankly, in watching the suffering and repeated suicides of my physician colleagues and beginning to understand that this is something that people do not feel safe enough to get help with, or do not have the hope anymore that something could actually make it better. I got really intentional about the things that are barriers to care. So I
Mhm.
would say from a starting place, physicians are very often fearful, and rightfully so, that any type of mental health information might be documented in an electronic health record that we all know loops back into the system, right? Not to pick on Epic, for instance, but we know that Care Everywhere shares those records, and that even though psychotherapy notes of some sort are supposed to have these extra protections, we know that people access this information. We know that institutional decision makers, risk managers can access that information for all sorts of reasons. And so because of that, first finding a provider that understands and really is intentional about that risk, I will go to the extent of maintaining paper records. They're back in style, right?
Hmm.
For my clients that are very much concerned about seeking support. And then I think also working with someone who is understanding of the fact that moral distress is perhaps a normative reaction to the environment that they're within, that the need to pathologize or diagnose that condition is not necessary in order to receive help. And by reaching out for help, that there often is a way that we can balance the risk of putting a label on something like that. And so to be able to provide non-diagnostic, whether we want to call it therapy, coaching,
Hmm.
support, but mental health care to manage some of this distress in a way that is not going to tank their careers or invite fear of getting help. I think that is one very tangible way that we can encourage providers to seek help.
One of the other points that you made in your article is that moral distress disproportionately affects clinicians with less institutional power or from those with marginalized backgrounds. So, talk about how those inequities intersect and exacerbate moral distress in these individuals.
Yeah, absolutely. So I think even the ability to speak about this issue comes from a place of privilege,
Hmm.
right? It is risky anytime a person chooses to talk about something that is not going to fit the existing narrative and the narrative that protects the institution. And so recognizing that those that are able to speak about it often do bear a certain type of privilege.
Hmm.
And when we're counseling those or perhaps trying to give advice on what someone should do, really acknowledging that not everybody has that privilege. And while it may be safe for one person to set boundaries, which is often a very well-intentioned piece of advice, right? You just need to set some
Hmm.
boundaries, that it may not be the case for everyone that they can just go to leadership and sort of say, I'm not going to do this anymore without serious consequences. And understanding that that affecting them disproportionately really can have a differential impact on their experience of distress.
How about those healthcare leaders who are listening to you on this podcast? What are some first steps that they can do from a health system standpoint to address the moral distress in the clinician staff?
Mhm. I think honesty and authenticity are scarce resources in healthcare right now. And I would say for any leader that wants to really take a step towards meaningful change, it would start with a recognition that just talking about psychological safety does not make a place psychologically safe. And in fact, if that's an area that's being actively discussed, it may be the case that it's a very psychologically unsafe place. And so, any sort of time that we approach these conversations, acknowledging the
Mhm.
fact that it is, in fact, imperfect and understanding that the ability to have peer support is often the very best first starting place, that the natural power differential between administration and healthcare providers makes it so that both sides are never going to entirely understand the other's experience, but where we can build in safety and we can build in solidarity amongst the care team to be able to then raise and elevate issues as a whole rather than a single individual. I think that brings a lot of power with it for people to make effective change. And for those that do speak up, for them to have the appropriate institutional protections for their jobs so that they are not retaliated against for bringing those concerns forward.
We're talking to Jenny Shields. She's a licensed clinical psychologist. Today's Kevin MD article is DSM-5 doesn't name it, but moral distress is everywhere in medicine. Jenny, let's end with some take-home messages that you would like to leave with the Kevin MD audience.
Yeah, I would say just for those that are in a position where they're questioning, is this it? Is this how it's going to be forever? What do I even want to do anymore? Or this feels unsustainable. and they're wondering what's next, I would just say that's really normal. I would say that most people that are coming to me, I work with people in 43 states now, they are seeking support for just being in a place that they're exhausted and they need to figure out what matters to them and what is next. And there are ways to get access to that support without tanking their careers. So I would just say, stock answer as it may sound, help is available. You're not alone. We don't want to lose a single other person to something like physician suicide. And if you've been too afraid to seek care, this is just your Mental Health May Awareness Month reminder that there are providers out there who very much want to be able to support you and to do it in a way that protects your confidentiality and need for privacy protections.
Jenny, thank you so much for sharing your perspective and insight. And thanks again for coming on the show.
Of course, thank you so much.